Thank you for joining us today. Today's Cancer Care virtual seminar topic is Understanding Cancer. My name is Annie Gebbe. I'm an outreach coordinator for the Samaritan Cancer Resource Center, and I will be your host and moderator today. This event is brought to you by the Samaritan Cancer Resource Center. We partner with anyone touched by cancer to provide the support they need to live with strength, determination, and hope into the future. Joining us today is Dr. Robert Davis. Dr. Davis is a medical oncologist with the Samaritan Cancer Program, and we are so excited to have you here with us today to go over a topic that's on a lot of our minds and giving us a really great overview. So thank you for being with us today, and I'll go ahead and turn the presentation over to you.
Well, it's great to be with you guys today, and I'm really an interactive person. I like the fact that a lot of you can tune into this talk in the comfort of your homes or wherever you want to be. But I do enjoy, being able to see people's faces and interact with them, take questions. And so even though the format of this talk is what it is, I designed this talk with that in mind. And I definitely would encourage you to type any questions that you have. I'd be, happy to take questions, and we can go into further detail if there's something that I touch on and you want me to go into a little more detail about it. That would be great. And I'll just give a little introduction about myself. My name's Rob Davis, and I've been working here for just over a year. So I think it was July 20th was my 1-year anniversary since I started working at Samaritan. It's been a great year. I have a little troop of my wife and 4 kids. They're all little. And we live here in Corvallis, and I am seeing patients in Corvallis 2 days a week. I also see patients in Lebanon 2 days a week, and I've loved both locations. So it's really great to be here, and I've been really impressed at how, all of the staff that care for our patients, and also the wonderful people that our patients are. And so they gave me a broad topic, introduction to cancer, and obviously there's a lot more than can be covered in the span of this short talk, but hopefully some of the concepts that I give will be helpful for you guys in your understanding, and I understand that there's people tuning in who are in very different situations. There's people who are, who have cancer. There's people who have had cancer. There's people who, family members, etc. I think all of us are touched by cancer in some way in our lives. Okay, this is just a brief overview of what I'm going to touch on during this talk. We'll talk about what is cancer. It's well known, but a lot of people don't understand it very well. And we'll talk about some of the causes of cancer. I'll also touch on cancer detection. How do we identify cancer, and hopefully earlier, sooner than later. We'll also talk about treatment options for cancer, and we'll go over management of symptoms that can be related to the cancer. And then we'll talk about survivorship. So when I talk about cancer, I like to start by talking about our cells. And so we are complex organisms. That in the human body, there are about 100 trillion cells, which is really one of those numbers that's just kind of impossible to comprehend. But so we have all of these different cells, and there's 200 different cell types. And by that, I mean the cells, you can think of them in many different ways, but one way to think of them is a cell as kind of like a factory. In a cell, there's a lot of production happening. there's a lot of exportation and importation, and there's a lot of communication. And so that's one way to think about a cell. And so there's 100 trillion of these with 200 different main types of what you could consider factories. They're organized into different organs, and so in our body we have many different organs, and there's different cell types for the different organs. There's some organs that have multiple cell types, and we'll touch on that a little bit later. And these 100 trillion cells divide on average every 24 hours, which is pretty amazing to think about. And so that's cell division, where a cell makes a new copy of itself. And each time they have to do that, they have to make a new copy of their DNA. And so that process is pretty amazing to think about as well. So in thinking of the cell as a factory, the DNA is really the code for how the cell works and how it does the things that it does. And the way that, this is a simplification, but the way it works is that we have DNA, which is a double helix. It's basically a long chain of what we think of as letters. And those letters are A, C, T, and G. And for simplicity, I am just using the numbers 1, 2, 3, and 4. Those letters stand for different purines and pyrimidines, and so they're in this structure, and it's a long chain, and there's 23 of these long chains, and each of them are condensed into what's called a chromosome. And this long chain is basically a blueprint for how the cell should make all the different things that it needs to make in order to do all of its processes. And so from a long chain of DNA, every 3 base pairs makes an amino acid. And then when you link amino acids together in a chain, that is able to form a protein. And proteins are really, the way that we do things inside a cell is through different proteins. And so looking at my example, we have different possible sequences. And so I actually just went on the keyboard and just randomly moved my fingers to type a combination of the numbers 1, 2, 3, and 4. And I came up with this. So if I divide them into groups of 3, we've got 1, 2, and 4, 3, 1, and 2, 3, 4, and 2, and so on. And if I am using the 1, 2, 4 sequence and looking at the base pairs, so 1 stands for A, 2 stands for C, and 4 stands for G. So that would be A, C, and G on that DNA chain. And A, C, and G code for a very specific amino acid. And so the DNA would be read, and that amino acid would be plucked and form the beginning of this chain. And in the chain that I have, there's 9 different triplets or groups of 3, and so it would form 9 amino acids that then would be chained together, and those would form a protein that would do something in the cell. You can see, for example, number 2 is 312, and number 4 is also 312, and so that would be 2 copies of the same amino acid, and they would just be stacked in this line, and that's how our cell makes things. And so here I have a protein made of 9 amino acids, but again, DNA is all one long chain. And so this sequence that we went through of 9 amino acids is just parts, and I have it in the bottom in red, of a much longer sequence. And so on that long chain, the cell has to know where one protein starts and ends, and where the next protein starts and ends. And that's that sequence that produces one protein is what we call a gene. So that's what a gene is. So on my long sequence in the bottom, what I have in red would be considered a gene. And those genes are named, you know, there's all these different genes in our bodies. So it could be EGFR. And some genes are very long. Some genes have hundreds of amino acids, and other genes are very small, and they produce proteins that have, you know, less than 100 amino acids. So the bottom line on my screen is what I want you to imagine is that we have this long chain, and the cell is getting ready to divide. And so it needs to make a new copy of the DNA. And when it makes that new copy, everything has to match perfectly. And it's incredible that our cell is able to do this with 100 trillion cells every day with such high fidelity. And there's all of these processes in place to make sure the cell gets it right when it makes a copy of its DNA. But it doesn't happen every time. And so sometimes it will grab, when it's making that new copy, it'll grab the wrong number, or it'll get off in what it does. And so what I put here is an error on the bottom, where instead of the 4, it should have been replaced by another 4, and it was replaced by a 2. And that is called a mutation. And so mutations happen every day as we go through this process of duplicating cells and duplicating DNA. Mutations occur in our DNA. And the consequences of those mutations depend on a lot of things. One of the things it depends on is where it happens. So maybe that mutation doesn't change the way the protein looks and functions at all. But if it's in an important spot on that protein, it can actually make it so that that protein no longer is working. Or it can actually activate that protein so that the protein is working a lot harder than it would otherwise. And so that's where mutations come in, and they can cause problems. And so there are some important genes when it comes to cancer developing, and those genes tend to be related to cell growth and the cell cycle. And so there's something called oncogenes, and oncogenes make proteins that stimulate cell growth and division. And so those oncogenes are not always supposed to be active, but sometimes mutations can occur that make them active, permanently, and that would give them a green light to continue causing cell growth and division, and create this process that becomes problematic. There's an example of an oncogene would be something called HER2. There's also proteins that their job is to keep the cell in check and stop it from dividing. So they're like the red light proteins. And those proteins are called tumor suppressor genes. And a common example of a tumor suppressor gene is TP53. And if a mutation occurs in one of the tumor suppressor genes that causes that protein to not work anymore in that cell, then it can be a real problem, because you don't have that red light and the cell continues to grow and divide. And so those are the things that lead to the development of cancer. And then there's one other type of protein. These are proteins that repair DNA. So when those mutations occur, there's actually processes where the repairs can be made to the DNA and those mutations can be fixed. And those proteins, one example is BRCA, are very important. And again, if there's a mutation that renders those proteins not working, not functioning, then that can lead to cancer as well. So that's a little, that's a little bit of an explanation of how cancer forms. And if you guys think about it, every time the cell divides, every time it produces a copy of its DNA, there's a chance of a new mutation. And so the risk of developing a cancer is related to the number of times the cell divides, because every time it divides, it has to make a new copy, and there's that risk of an error happening. And that's why cancer is really a disease. Obviously, younger people can get cancer, but generally speaking, it's a disease of old age. If you live long enough, then you will develop cancer because your cells will go through that division process enough times to accumulate mutations in the genes that can cause cancer. And so one of the, I guess, the main risk factor for cancer is aging, and all of us do that, and so all of us are prone. Speaking of what is cancer, so cancer starts with a cell, and when we think about some of these infectious diseases, and that's on our minds because of COVID, we think about where did it start and who was the first person to get infected. Because it all took off from there. And it's the same with cancer. Cancer always starts with one cell. And in infectious diseases, we think about patient zero. With cancer, there's that initial cell that developed those mutations and became this problem cell. And I describe it as a cell that goes through red lights, meaning when it's not supposed to be growing and dividing, it's doing it, and that's the problem. Going into what causes cancer and what doesn't, we talked about age and mutations that accumulate over time. There are also carcinogens, and carcinogens are anything that increases mutations. And so there's environmental factors that can cause cells to have mutation. A prime example is the sun. When people are exposed to UV light, it can cause our skin cells to have mutations, and that can eventually lead to skin cancer. And then, of course, we know that in cigarettes, there's many different chemicals and substances. And many of those chemicals and substances are carcinogens. And that's the way they cause cancer as well. They lead to increased mutations in the cells that are exposed to them. So in the case of cigarettes, it can be cells in the head and neck. It can be lung cells, etc. There's also, so there's mutations that our cells can develop over time. But there's also mutations that can be inherited. And so there are some genes, and the most, I would say the most famous one is BRCA, where some people carry mutations in those genes in their DNA that they inherited, and those can be passed down from generation to generation. And those can increase the risk of developing cancer. I brought up Roundup because I get asked by a lot of patients about it. There is a class action lawsuit against Roundup, and there is some evidence, although it's not 100% clear, it's enough that it has allowed this lawsuit to come forth about Roundup causing lymphoma. And so, there are chemicals in Roundup that potentially could cause something like that. And I thought I would bring it up just because I get asked a lot about it. I also get asked, does sugar cause cancer? And if I have been diagnosed with cancer, should I stop consuming sugar? And that is actually a myth. So there is no evidence that increased sugar intake leads to an increased rate of cancer. And in studies where they've looked at different groups of people with different diets, they're not able to identify an increased risk of developing any kind of cancer based on the increased sugar intake. And the reason that I think one of the reasons that people think a lot about food and cancer is because food, so many aspects of cancer are out of our control, and that's hard. We want to have control over something. Food is something that we can control, and so we think about our diet, and if we control our diet better, can that increase or decrease our odds of getting cancer? And there are actually a few foods that increase the risk of cancer. One example is highly processed foods, especially processed meats like hot dogs and salami and stuff like that, can increase the risk of colon cancer. But generally speaking, it's good to eat healthy. It's important, but there's not a strong cause and effect with eating certain foods and developing cancer. For a patient who has cancer, the most important thing is for them to continue getting nutrition. And so I counsel patients to avoid these extreme diets that really limit sugar intake because. So when we talk about different types of cancer, this is a long list, and this is not a comprehensive list. But this list is just to highlight how cancer can be developed in different organs. And whatever organ the cancer starts in, even if it goes somewhere else. So let's say the cells start in the breast, but then they go somewhere else like the brain or the bones. It's still considered breast cancer, even if it's in the brain or even if it's in the bones. And so let's go through a few of these. So I have the first one listed is breast. And the kind of cancer that comes from the breast is called adenocarcinoma. And adenocarcinoma refers to the cell type that it comes from. Those are glandular cells that can become cancer. So that's why it's called adenocarcinoma. And it can come from both the ductal or the lobular. And then on this list, you guys will see a lot of adenocarcinoma. Adenocarcinoma of the prostate, adenocarcinoma of the lung. But there's different kinds of cells in the lung. And so lung is one where we can get adenocarcinoma, but there's also a different kind of cell called squamous cells in the lung. And so you can get squamous cell lung cancer, and then a third type is small cell lung cancer. And then going down the list, there's a lot of adenocarcinoma, there's a lot of squamous cell carcinoma, and then there's a few different organs where they have very specific cells, and cancer develops from those specific cell types. So an example is liver, where you have hepatocellular carcinoma from those specific liver cells. So multiple different kinds of cancer can develop in the same organ, and depending on what type in that organ, they can be more or less aggressive. How do we know if we have cancer? Often people don't know that they have cancer, but there are some symptoms that everybody should be aware of, and some of those symptoms are related to cancer type. And so for an example would be colon cancer. So some potential clues about colon cancer could be blood and stool, constipation, or abdominal pain. And these are things that can be common. Some people get abdominal pain frequently, But if there's a pattern where it's consistent abdominal pain, or it's accompanied by any of these other things like constipation or blood in the stool, it should prompt you to get evaluated. And that initial evaluation is usually with a primary care physician. And so it's important to have a good relationship with your primary care physician so that if something does happen, you can have confidence to go and see them, and they know you well enough to know what is normal for you and what is maybe something new or something concerning for to look deeper, just to see if there's something like cancer. There's also generalized symptoms that people should pay attention to. So a lot of people have fatigue, and there are many reasons for us to have fatigue. One of them is cancer, but if you notice a real dip in your energy over any sustained period of time, it's also worth going to see your primary care physician, because it can be a sign of something like cancer. And then another one is unplanned weight loss. Another one would be decreased appetite. Those are things that if they're consistent over a period of a month or so, it's worth getting it checked out, because it could point to a diagnosis of cancer. As far as cancer detection, there's certain cancer types where we have good screening tests, and those are recommended because not only can they detect cancer in its early stages, in some cases they can detect abnormalities that can be removed before cancer even develops. And so as we go through, this is the same list, and I've highlighted in red where we have screening tests or things like that. So with breast cancer, women are encouraged to get mammograms. With prostate cancer, it has gone back and forth about whether checking a PSA level, which is a blood test, is a good screening test for prostate cancer. And the reason why is because it does lead to increased detection of prostate cancer, which is good. The counter argument is that it can also be elevated for other reasons than prostate cancer. And so sometimes an elevated PSA leads to a biopsy when the person doesn't actually have prostate cancer. But it still is out there, and it still is a screening test that can be used. For lung cancer, there's a recommendation that people who are smokers should get an annual low-dose CT scan. And then for colon cancer, there's also a recommendation that people should get a colonoscopy starting at the age of 50. And actually, some groups are suggesting that we should start earlier at the age of 45. And part of that is related to colon cancer becoming more prevalent in younger people. And that's a trend that we have seen over the past few decades. Colonoscopy isn't the only test for colon cancer screening, and there's some other FDA-approved tests where it detects blood in the stool and things like that. And then there's other cancer types where we really don't have a good screening test. And some of those are for pancreatic cancer, for ovarian cancer. And so unfortunately, those are two types of cancer where often when people are diagnosed, it's in a later stage. But if pancreatic cancer was suspected, one thing that can be checked is the blood for increased bilirubin, and also a CT scan can be checked. And I won't go all the way down the list, but I wanted to highlight at the bottom, skin. As we age, our skin, we get moles and we get all kinds of other things. And most of those are benign, but what if it's not? It's always good to have a dermatologist tell you that your mole or whatever is nothing to worry about. And I would definitely recommend people to go see a dermatologist at some point in time, and especially if they have questions about a spot on their skin. So now going into when cancer develops in whatever organ. So again, I'm using the example of breast cancer. We have treatments, and the treatments depend on different things. One of them is the spread of the cancer. And so in this table, I have the first column is location. And the 3 rows are local, regional, or distant. And I think it's helpful to kind of go back to that example of the infectious disease, and we can use COVID and go back to that patient 0. So when that first cancer cell develops, well, it's going to divide. That's what it wants to do, and yet it initially will divide locally, and if you can contain whatever region where it is and give a curative treatment, if you can catch it at that point, you potentially can completely get rid of it and cure the cancer. And that's how it is, if you think about these infectious diseases, the goal is to catch it early and then contain it so that it doesn't spread. And then the next way that cancer spreads is regionally. Usually maybe it gets in the lymphatic vessels or just in the tissue in the surrounding area. And when in that case, it's usually considered stage 3 if it's in lymph nodes, and that can be stage 2 or 3 depending on the cancer type. But at that stage, it's still potentially something that can be cured. And the treatments that we use to cure cancers that are local or regional can be any one of a combination of these 3. The main one is surgery. Cut it out, get rid of it, because if you can get rid of that locally contained area, then you can get rid of the cancer. Radiation is also used, and medicines can be used. So in the example of breast cancer, often patients get surgery, and then, depending on certain factors, they might be recommended to get radiation. And radiation is effective. It's a local treatment that can kill any surviving cancer cells in that area. And then medicines obviously go throughout all of the body. And so if there's medicines that can kill cancer cells, they're able to treat cancer cells wherever they happen to be in the body. The last row is distant. And what I mean by distant is that it has now gone to a location that is outside of its local region or neighborhood. And so this is somebody who is sick who gets on a plane and flies to Europe or flies, to a different state, a different continent, a different country. When cancer does that, it can do that by way of the blood vessels or the lymphatics, and it can go to a distant location. And that is what we define as stage 4 cancer. So stage 4 cancer is where it started somewhere, and now it has gone to a completely different part of the body. And one thing to highlight, for example, is lung cancer. So if lung cancer starts in the left lung and it crosses the midline and goes into the right lung, that is considered distant. And so that would be considered a stage 4 lung cancer. And the way we treat stage 4 cancers is usually with medicines and sometimes with radiation. So in stage 1 to 3, a couple of points about those are, one is that they're curable. However, they can be resistant to your treatment, or they can potentially come back. And it's for those reasons that sometimes we do multiple treatments, surgery and radiation and medicines, with that goal of preventing them from coming back. The second point is that treatments are used to increase the chances of success. And there's two terms that we use. One is neoadjuvant, and that's when medicines or radiation are given before a surgery to remove the cancer. Adjuvant is when medicines or radiation are given after a surgery. And one important consideration is that the duration of treatment is finite. Sometimes with patients with breast cancer who are looking at 5 or 10 years of being on endocrine therapy, it can seem indefinite, but there is a finite period of time for that treatment to occur. In stage 4, it is generally speaking not curable. And the reason I put an asterisk is because there are exceptions to that. One exception is blood cancers. Blood cancers, no matter if they're stage 4, are potentially curable. Another potential exception can be head and neck cancers. Generally, as long as they're still in the neck area, even if they're on the other side of the neck, it potentially can be cured. And then we often, if there's a colon cancer that has spread to somewhere like the liver, if there's if there's only one or a few spots where we can see that the tumor has gone, we often treat them aggressively, and sometimes we're able to cure those cancers as well. And so the goals of treatment with stage 4 cancer, we're no longer, our goal is no longer to cure the cancer, although we would love to. The goals of treatment are to control the cancer, to make the tumor shrink and prevent additional growth, also to relieve symptoms. If the cancer is causing symptoms, for example, shortness of breath or weight loss, decreased appetite, then sometimes treatment of the cancer can restore, the appetite or take care of some of the pain. And then the other goal would be to extend life. And it's really important for us when we talk to patients to not just impose our goals on the patient, but also to talk to the patient about what are their goals. And one important conversation is sometimes somebody's quality of life is more important than their quantity of life. And so we need to be aware of those considerations so that we can tailor treatments to their priorities. And then for stage 4 cancers, generally speaking, the duration of treatment is indefinite. And so they may not be on the same treatment the entire, for that time, but often they're going to be on some kind of treatment indefinitely. So now I wanted to talk about medicines that we use to treat cancer. And we talked about how there's 3 different treatments for cancer: medicines, radiation, and surgery. And so different doctors manage each of those different kinds of treatment. There's surgical oncologists, there's radiation oncologists, and there's medical oncologists. And I am a medical oncologist, which means that I use medicines for the treatment of cancer. And those medicines are not just chemotherapy. There's 4 main groups of medications that I wanted to highlight. One is hormonal therapies. So there are a lot of cancers that are stimulated by hormones, and there's medicines that block those hormones that stimulate the cancer cells. They can be oral medications or injections, and some examples are Lupron, which is used to treat prostate cancer by blocking testosterone, and tamoxifen or letrozole, used to treat breast cancer by blocking estrogen. Chemotherapy, the way chemotherapy medications work is going back to what we talked about DNA. Well, chemotherapy medicines target DNA and target the structures used by cells to divide. And so there's chemotherapy medicines that coat the DNA, making it impossible to copy. There's DNA medicines that cause mutations in the DNA. And there's chemotherapy medicines that block the cell's ability to divide. And because of that way that they work, it's not specific to cancer cells. And so some of the side effects people get from chemotherapy are related to their normal cells having problems dividing because of the effects of the chemotherapy. Chemotherapy is often via an infusion, so a bag that goes in through the IV, but there are also some oral chemotherapy medicines. And some examples, we often use combinations of medications, and so we have these chemotherapy regimens. Some examples are dose dense AC, followed by Taxol, which is commonly used in breast cancer. R-CHOP is a regimen that is commonly used in lymphoma. FOLFOX is commonly used in colon cancer. And then an example of an oral chemotherapy medication is palbociclib, which is Ibrance, which is used in breast cancer. And a really exciting advance in the treatment of cancer over the last 10 years has been with immunotherapy. And the first immunotherapy was FDA approved in 2014. So these have been around for about 8 years. And immunotherapies are often infusions. And some examples are pembrolizumab, which is, the brand name is Keytruda, or nivolumab, which is Opdivo. The way that they work is that they help immune cells detect cancer cells, so that the immune cells can do their job. And one of the jobs of immune cells is to identify and kill cancer cells before they can colonize and start, and form a cancer. And the way they do that is that cancer cells try to hide from the immune system. And one of the ways they try to hide is they express a protein on their surface that's called PD-L1. And PD-L1 reaches out to an immune cell and kind of makes a handshake with that immune cell. And that handshake is kind of their agreement that the immune cell will not try to kill the cancer cell. And so when it makes that agreement, it allows the cancer to survive and to form a tumor and to start cancer. And those immunotherapies block that connection between the immune cell and the cancer cell and kind of pull the blindfold off of the immune cells so that they can see and kill the cancer cells. So often when we're checking to see how effective immunotherapy would be, we actually check to see the level of PD-L1 protein on those cancer cells. And we're now using immunotherapies in many, many different kinds of cancer. I think over 20 different types of cancer. And there are FDA approvals for also when we see certain characteristics, it doesn't matter what kind of cancer, we're able to use immunotherapy. And immunotherapy is mainly used to treat stage 4 cancers. But occasionally it can be used to treat earlier stage cancers to decrease the risk of them coming back. And then the last medication type is targeted therapies. So targeted therapies, going back again to that DNA slide, we have all these different genes, and targeted therapies target mutated genes that are involved in cancer. And so those can be oncogenes, or those can be tumor suppressor genes. And they're often pills, so they're often oral medications. And one example is osimertinib, which is Tagrisso, which is used to treat lung cancers with a mutation in a gene called EGFR, which is an oncogene. And so when that mutation is driving the cancer, and we're able to give a medication that blocks that mutation, that whole process of the cancer is, sometimes is able to be reversed. And so that's another incredible advance in the last 10 years in the treatment of cancer. So it's not just chemotherapy, and that's something that's important. There are a lot of patients who have seen family members or friends really suffer with chemotherapy treatments for their cancer, and feel like, why even go see a medical oncologist? I know that I don't want chemotherapy. But it's still worth having that conversation, because there may be a good medication that's not a chemotherapy that can still effectively treat the cancer. Now, a couple of things regarding symptom management. That's a very important part of cancer care, and it's something that is the responsibility of oncologists. And we also have a specialty that's called palliative care. And there's really good palliative care doctors that can help us with managing these symptoms. Some common symptoms can be nausea, and there's medicines, and there's also CBD products that can help with nausea. And just a note on CBD products, those can be effective in treating many symptoms related to cancer. And in our cancer center, we have dietitians, and we have dietitians who are able to give counseling in patients about what what CBD products or marijuana products can be helpful in managing some of these symptoms. There's pain that can be associated with cancer. And radiation to a certain spot that's really painful can be an effective treatment to relieve that pain. Also medicines, and we use a lot of medicines to help treat the pain related to cancer in our patients. There's low appetite and weight loss. And again, our awesome dietitians in our cancer center do a great job in counseling patients. We also can use medicines or CBD products to help manage the appetite and weight loss. Often, just treatment of the cancer itself can be the best way to treat the symptoms related to the cancer. And often, patients feel a lot better after getting a few treatments for their cancer. And that's one of the reasons, we do these treatments, is to improve quality of life. And then emotional support is so important, because cancer doesn't just affect our body, it affects our minds and it affects our emotions. And I think the Cancer Resource Center is a prime example of a great resource we have for that. We also are able to connect people with our awesome social workers, and then palliative care physicians. And not only palliative care physicians, but teams are equipped to help with those needs as well. Survivorship. There's a quote on a screen in our cancer center that's from Holly, one of our nurse practitioners, that says, "Survivorship starts from the time of diagnosis." And survivorship is referring to helping basically surviving cancer. And that includes, after the completion of cancer treatment, surveillance, which means doing what is necessary to keep an eye so that the cancer doesn't come back. And that's a source of anxiety in a lot of patients. And depending on the cancer type and also the risk of recurrence, surveillance can be more or less aggressive or intensive. And so that can include office visits, it can include blood work, and it can include scans. And for different cancer types, different things are recommended. We love for our patients to be able to not think about their cancer. And kind of be free from that. And we know that when there's an upcoming office visit or blood work or scan, it makes patients think about it, and it increases anxiety. So we don't like to do that more than is reasonable. But also we want to give patients the surety through these things that the cancer is hasn't come back, that it is still in a state of remission or cure. And usually as we get farther out from diagnosis, that frequency of visits decreases. So that covers, those are the different things that I wanted to cover. And so just a couple of take-home points, and then I'll open it up to questions. Cancer risk increases with age. As we age and our cells divide over and over again, those mutations can accumulate. Some cancers are preventable, and many cancers can be detected early with age-appropriate screening. So important to do those things like colonoscopies, etc. All cancers are treatable, but treatment goals depend on the cancer type and its stage. And great progress has been made in medicines used to treat cancer even over the last decade. And then finally, at Samaritan, we are committed to giving the best care to all patients. And with that, I want to thank you for your time and turn the control back over and take any questions that you guys have.
Thank you for that, Dr. Davis. That was so informative, and I really appreciate the time you took to kind of take us back to basics, because we've had so many very specific cancer talks in the last few months, and I think going over an overview of what cancer is and all of the different facets is super helpful to hear. So thank you so much.
Yeah, my pleasure. And are people able to submit questions via chat or anything like that?
Yes, so if anyone has any questions, please submit those now. There is a gray questions menu that you can input your questions at. And while I give you all a couple minutes to do that, I'm going to quickly go over some information and resources. If anyone on the call or knows of anyone who would like to obtain more information or resources about cancer, please feel free to reach out to us at the Cancer Resource Center. We can be reached by phone, email, Instagram, Facebook. You can swing by our office and come in and say hi to us. Any of those ways that you would like, please contact us. We are happy to help or get you to the right person if you have any questions or concerns. And if you'd like to hear about upcoming events, the best way to do that is by checking our social media or by joining our monthly newsletter. So if you'd like to join that, please contact us. And coming up next, we have Cancer and Sexual Health, Part 2, which will happen on Thursday, August 11th. And at the end of the month, we're going to be joining the Oral Cancer Foundation for a walk/run at Willamette Park. So if you'd like to learn more about how to sign up for that, please contact us. We'll be happy to walk you through the registration process. And now we'll get back to questions. I haven't seen any questions or comments pop in quite yet, just a couple of thank yous for your time.
You guys are letting me off easy.
You were so thorough. You left no room for questions.
I do want everyone to know that, even if you're not a patient of ours, if you do have any general questions about cancer, we're happy to answer those questions. We want to interact with you. And so just call the Cancer Center and they can pass that on, my personal invitation to pass those questions on to me.
Thank you. And I second that. Please reach out to us if you need anything. And if a question does pop into your brain later today or while you're falling asleep, feel free to message us and we can definitely field those questions through the Resource Center to Dr. Davis and get you the answers you need. Just so you know, there will be a survey popping up on your screen and via email after the presentation if you'd like to give us some feedback and let us know how we did, or if there's other topics you'd like to hear about. We do appreciate you filling those out. And with that, I just want to let everyone know we really appreciate your participation. Dr. Davis, thank you for taking the time to educate us on this important topic. And I hope everyone has a wonderful day.